successful surgery. And if there are no other questions, so I will like to invite our dynamic secretary, Dr. Shamsul Huda, for his a very important talk on tips and tricks of the Ilizarov surgery. And Jyodeep, if there is any question, then please go ahead.
Possibly there is no question, sir. So I will ask Dr. Shamsul Huda, sir, to begin his talk. So Dr. Huda, sir, is our National Secretary of ASAMI, India. So after doing his MS Orthopedics from KMCH Katihar, he did his MCH Ortho from Seychelles, USA, and also did his Advanced Orthopedics Deformity course from Baltimore. He has done his diploma in Ilizarov techniques from Kurgan, Russia. He has attended multiple conferences as national and international faculty. He is also a co-author and contributor to Orthopedic Principles, a review book by Dr. Hitesh Gopalan. So I will ask Huda sir to begin his talk on tips and tricks in managing fractures with Ilizarov.
Thank you, sir. Thanks, Jyodeep, and thanks to West Bengal Orthopedic Association. Thanks, Vera, sir, for giving us opportunity. And really, thanks, Vera, sir, for creating a very useful talk for the youngsters. My screen is visible?
Yes, sir. It's visible.
Yeah. So after the very important talk about the biomechanics, I'll be talking about the tips and tricks in managing fresh fractures with Ilizarov. So all about when to apply Ilizarov, when not to apply Ilizarov, when to apply X-Fix. So we have to be very judicious and very tactfully deciding how to apply, what to do next. So suppose you get such major post-traumatic complex injuries, it's very difficult to and very dicey to decide whether you can amputate the foot or salvage the foot. So you have to check all the multidisciplinary action the patient is surviving or not. You have to see the distal pulse. If it is all okay, you can put a slab or an X-Fix. And many times you see that we just end up with a X-Fix put on for a longer time like this, and we end up in a equinus foot and stiff knee or something like this, like a deep pouring plus for 6 months. So X-Fix, putting a slab is very good. Don't put it for long. If the limb is surviving, if it is compound, if it needs a good fixation, if you need a good unit, you have to go for Ilizarov. So you should always keep your over the Ilizarov instrumentation, and you should be having the Ilizarov trained brain. Then you can do a limb salvage in maximum number of cases. So in any complex compound orthopedic trauma, you have to see first the ushered problems like shock, the blood loss, head injury, visceral, maxillofacial injury. We have to see the critical care like multidisciplinary approach, hemostasis, hemodynamics, and for the limb, then limbs comes the next. We have to see the comminution, compounding, compartment, neurovascular injury, bone and soft tissue injury, loss, degloving, infection, and there is infection. So if you calculate all this, then we can go ahead for Ilizarov. Before we plan for Ilizarov, we have to go for different diagnostic protocols like X-ray for grading and planning and evaluation, CT for head injury and abdominal injury, then 3D CT for comminution, grading and planning of the different comminuted fragments. You cannot apply a plate. You can apply Ilizarov and Olip from multiple directions, much better than a plate in these cases. So we have to see for the 3D CT, then CT angio for vascular injury, MRI for soft tissue, cartilage, nerve in the spine, and ultrasound for the visceral injury. So you all go ahead before operating any compound fracture with the Gustlow and Anderson's classification to decide whether what should be fixed for. So in type 1, we can easily and safely go for internal fixation like plate or nail. In type 2, when there is a big wound greater than 1 centimeter, Ilizarov becomes an option, but you can do an X-Fix and skin graft also. Type 3, when there is open fractures and soft tissue, muscle injury loss. So have to go, there's a comminuted combination. We have to go, maybe do a skin graft and flap. So Ilizarov becomes a better option here. Type 3B, when there is extensive soft tissue loss, there is peripheral stripping, bone exposed, bone loss, contamination. Ilizarov becomes the true indication in these cases. We have to do loose bone removal, may have to do at times bone transport. Type 3C, where there is open fracture, arterial injury, it may need repair. And if the limb survives, Ilizarov is the definitive treatment. So let's see the few advantages with Ilizarov. It gives a circumferential support which no other implant gives, no plate, no X-Fix gives except Ilizarov. We can do 360-degree fixation of any fracture, and we cannot do weight bearing in all the other cases except in Ilizarov. We can do next post-op day full load bearing, comfortable walk, and follow the law of tension and stress, and we can all do all the soft tissue procedures like graft, flat, vac can be done. There is no joint stiffness if you just use use of hinges or periarticular favorite rings, and we just start a good rehab. So there is no joint stiffness. In many cases, when there is intra-articular, we have to do span the joint also, and it is a modular implant. In plate or nail, you cannot do any adjustments later, but in this Ilizaro, you can do all the adjustments later, like displacements, angulation, compression, distraction, can be corrected gradually. And in case of bone loss and bone transport, we can do the transport as needed. Patient can be trained well for self-dressing. Patient can go home with the ring on, come back for corrections. The minus points are that it is a very cumbersome device, very heavy device. Patient compliance is very bad at times. Patient will be coming to you many times. Please remove the ring. Don't. Wait, do counseling is very important. Wires if not taken properly can cause pains. The duration may be very long, starting from 3 months to 2 years. So counseling is important. You have to do very meticulous care of the pin track so that it doesn't go for infection. If it is an infection, you have to remove the pin or the wires, put another wire, do dressing also. It's very important. And if the wound is bad, the dressing becomes difficult. So you have to do very training for the patients. So the basic protocol we'll be following for any fractures that may end up in Ilizaro, that just to repeat again, we have to see the viability of the limb, we can salvage the limb, then stabilize with the multidisciplinary approach like critical care, anesthesia, neuro, maxillofacial, ortho, and plastic surgeon. And then we plan for orthopedic surgery. We have to span and elevate and do thorough debridement. Debridement is very important in all the cases. You can apply slab or F6, and then flap is needed, and check for compartment, gangrene infection. If it is all okay, you can wait for 1 or 2 weeks. You can plan for Ilizaro. Don't wait for 6 months to put Ilizaro. If it is okay, you have to save the limbs. You have to go for union, go for Ilizaro. After 1 to 2 weeks, everything is fine. So before applying Ilizaro, you have to evaluate for viability, compound, comminution, bone gap, bone loss, and any neurovascular or tendon injuries. When you are planning for Ilizaro, you have to check for the rings. How many rings? 2 rings pre-fracture, 2 rings post-fracture. The placement of rings according to the fracture. Reduction is very, very important. We have several reduction maneuver I'll be talking about. Like we can do lifts, control lifts, oblique fires, reduction techniques, add-ons like TENS. And as Beras has said, mechanically, the ring has to be very, very stable for a good fixation, for a good union, for a good transport, and for good results. We have to span the joint so that there's no laxity of the bone. Joint, the ligamento-taxis is very important, especially in the periarticular fractures like Pulleys or Palon or Schatzker. And then if needed, we have to go for bone transport. We have to check if it is distal fracture or if we are going in equinus, we should always apply a foot frame. So in our OR, you always keep to be safe, to save a life, this Ilizaro box to save a life. You can anytime change your plans from X-fix to or plate to Ilizaro. So before applying Ilizaro, you should have everybody should have a basic knowledge of the safe anatomical zones on the upper and lower limb, which is a separate talk. So these are the examples of the level-wise wire modified diagram besides the regular one. So you can see green is the safe zone. We have the list of these diagrams. Yellow is the moderate zone, and red is the high risk zone. So you should have a very good knowledge of the anatomy before applying Ilizaro. And after that, you should know how, when, and where to apply Ilizaro. So you need to know the configurations. So these are the various configurations. All the youngsters should remember. These are the shoulder, arm, and elbow configurations in different parts of fractures of the humerus. These are the fractures of the olecranon. You can see it works very well if the skin is bad. The elbow joints can use in the elbow joints 1 ring, 2 rings to 4 rings as needed. These are the forearm and hand configurations in the wrist and Colles fracture, intra-articular fracture. Where there is a compounding, you can always use a Ilizaro with full range of motion and activities. These are the femur configurations starting from hip to shaft of femur to knee, distal femur, and the proximal tibia. All types of fracture can be held well with Ilizaro. These are tibia configuration, the proximal tibia, the mid shaft, the distal fracture. These are the foot and ankle configuration for trauma, for deformities, for calcaneum, the foot, and all that different fracture of the foot. Yeah. So this is the ideal fracture tibia frame. As Biras has said, mechanically has to be very stable. You have to follow the rule of 2 rings proximal to the fracture, 2 rings distal to the fracture. There should be 2 finger breadth away from the fracture, 2 fingers above the anterior skin. And you may use wires and shanspin as needed. You can use hybrid. As the young surgeons are comfortable, we should use olives and contour leaves for compression. Biras has defined it very well. And as Bera said, asked me to tell about this drop bars. The role of drop bar spins are very important for mechanically stable. Suppose we are using a periodical transport. The fragment is very, very small. You just have one 5x string. So you can apply this drop bar spins to stabilize the ring in all the parts. This is the mid fragment, transport fragment. This is one ring. There are drop bars over here. There is drop bar over here. These are drop bars are very important for compression. After compression, you can see this will be bending so that you can end up in a very good union and a very good transport. So drop bars give a very good mechanical stability as told by Bera sir. And we have to span the ring for diastasis. The spanning is very important in all the cases so that the joints, that ligaments heal very well. And if you apply a period this shaft, I usually use 5-bed in mid-tibia fracture so that we can have a full range of joint movements. But if it is an intra-articular fracture, we can add the spanning in the nearby joint for around 4 to 6 weeks, so it heals well. So these are very, very important tips. All the youngsters should learn very well. Let's see a few basic fracture reduction techniques before we do all Ilizarov, so that we may not need to open the fracture. This is a very bad elbow fracture. It was communicated has a very bad wound. You can just use half ring and a single wire in the allocanon. Traction as well as joystick. You can see end results. It's a very beautifully reduced well. You do not need to open this in many of the cases, maximum cases. Just in a few, there is a rotation. You have to do a mini open. So these are we can do manual traction and joystick. Then there are several other techniques like distraction for periarticular fracture. Distraction gives a very good result. Rotation with the shank spin, with the different Ilizarov rings, we can have the proximal and the distal fragment rotate, fix, and then finally we can fix with shank spin to hold the fractures of the wires or the drop wires. Methodologies are different, principle is the same. So these are for the different angle wires or pins for angular corrections. And these are this angulation we can do is apply this, remove the frame, use hinges in the frame, and correct with the hinges. So these are different methodologies. There is a separate chapter for this. Fracture reduction techniques are very, very important. This is olive wire technique. You can just use olive wire technique to just do the transport as well as angular correction, as shown in the diagram. This is joystick technique. This is towel technique. Just put a towel down and elevate the whole limb upstairs so that you can have a good direction. This is laminar spreader technique. You can apply 2 shank spin over here. Just do a laminar spreader to reduce the fracture. These are very small, very important techniques. You can use in all the fractures so that you do not need to open the fractures because it is already compound. You can have very good result. And after that, you have reduced the fracture. You can put more shank spin or wires just to hold the fractures. You can use contour leaves. These are very important techniques. This is the draw wire technique. Just to hold this fracture like this. This is the arch wire technique. You can use the arch. One fragment is down, one fragment is up. You can use the arch like an arch and put a wire here, put a wire just above the fracture. As you tighten, it takes the fragment up. So it reduces very well. So you can use in femur and tibia and all the fracture, but you cannot without opening. So arch wire techniques which works very well. There are other techniques like free wire technique, percutaneous laxo technique, walking length rings, and limited small plate fixation. Dr. Reza sir has a beautiful presentation on a temporary fixation on the plate. So this is a very important technique. Reza sir has taught us many times. And these are the droppers again, like Bera sir told us. The droppers, when you just do the final compression, the droppers go curved so that it gives a very good compression. We can get a good union later. Dropper gives in all the rings very good stability. You should always use droppers or drop pins if you cannot apply more than one ring in the fragment. You have to do large bone transport or more fixation. So drop pins are very important role. So you can use olives and control leaves and for reduction in various cases. These are the multiple olives. You can reduce the fracture and then apply a ring later. So these are the compound tibia fracture. You can apply tens inside. You cannot apply this. Apply olive for compression and give compression with the 2 rings so in between. So you can use internal and external both fixation for different techniques. For the short stress fracture, you can use multiple leaves from all the direction: posterior, medial, posterior, lateral, not posterior, lateral, medial, lateral, and you can have a very good direction afterwards. When there is a transport or actual deviation in long bone transport or even in fracture, you can use different methodologies for transfer this deviation correction, like olive wires, like wrenching give shank spin deviation techniques. You can do rotational direction, you can do deviational correction, you can do angular correction, you can use hinges, you can use again the class in the shank spin. So let's see a few cases before we go to the rehab to understand how you use in different cases. This is a proximal distal humerus fracture. It's a compound fracture, much infected. You cannot apply a plate. You cannot apply X-fix, will cause stiffness. So do a very good debridement in all the compound fractures, whether it is in any limb. And after that, you can do thorough wash. You can just reduce the fracture with multiple olives in this case. And again, after that, you can apply the rings as needed. Normally, we use pre-loaded rings, but in this case, it should do like this. Reduce it very well, apply. You can use different hinges and bolts to just hold the fracture. And this is very important idea to reduce any periodical fracture. Rows of olivers and use the rings and the post afterwards to hold it. You can see such a wonderful, beautiful union in all these cases. This only Ilizarov can give this, no plate can give this. You can see a very good union in just 3 months. And you cannot delineate which limb was operated. The scar is so good. And you should always promote early range of motion, early rehab to get good results. Similar cases of distal humerus, I'll not go into detail. And the similar in the forearm, coming from the arm to forearm, is a compound fracture. You can apply Ilizarov, you can do hold the fracture well. And then you can do the skin graft later also. You can just remove the wires from here, apply skin graft, again put the wires back. So you can always apply, do skin graft in all these cases. You can also do wires inside also to hold the fractures. Rehab is very, very important in all these cases. Similar cases of distal humerus fracture, you can put two wires also so that you get a multi-directional support. Range of motion rehab is very important. You can get good results. Come to the lower limb. So these are the large bone gap fracture. You just see similar of neglected, delayed decision for Ilizarov. Patient was in X-Fix for 6 months, came to me with a stiff knee, with a stiff ankle and equinus foot. Don't wait for this complication to come. You can put a slab or X-Fix, as I said earlier, but wait 1 or 2 weeks, apply Ilizarov if you want to do final surgery. So this is a long dead bone gap. You have to remove this bone gap. You can just smooth edges. And you can do bone transplant in all the cases. To get a good result, foot frame is very important in all these cases to avoid squamous. Foot frame is very, very important. After transport, you should apply a brace or a slab for sometimes to just hold the fractures. The similar cases of long bone gap, not going to details. You should always do full load bearing next day also only. This is very important. These are all comminuted fracture, X-Fix was applied, removed. Make the edges very smooth so that you have to calculate. So in this fibula is shortened, you should do spanning. This is not spanned. You should do spanning. Spanning is very important. So you should maintain the length. As you can see, there is a valgus deformity. You have to correct post-op. You can use olives, you can use hinges over here to correct the valgus. You can stack the ring. So these are very, very important points. Even you can see post-op, the excess not good. Do a minor surgery, apply some olives, apply some hinges. I can change the direction. Okay, it's very important. So let's go to some other cases like distal femur fractures. You have to span the one ring below. So there is a periapical fracture. So spanning the joint is very important in periapical fracture for some time to get a very good result. And this is another case of tibial fracture. This is the use of Ilizarov in primary fixation. We have not applied anything like X-Fix, just a slab, wait 4 to 5 days. And you can see not apply a nail because of the bone was exposed. You have to apply Ilizarov, put some olives wires over here to reduce the pains. And we can do a skin graft later. So this is a use of very regular cases of Ilizarov. Youngsters can do this. Case of Startska fracture, proximal tibia, as I showed earlier, did very well. You can do skin graft lateral over Ilizarov. These are pylon fracture coming to the lower part of the ankle. You should use the oblique wires for reduction, olives and quarter. These are very, very important. Use of oblique wires for fracture reduction and holding is very, very important. Again, in these cases, you can again do skin graft later. So this is another interesting case of a very bad crush injury for young girl, 17 years, amputated knee. Patient was advised to do articulation from the hip. Patient was ready for suicide. We just gave her hope, and multiple skin graft plastic surgery was done. X-Fix was applied. There was an infected non-union. LRS was applied. Unfortunately, less pins were applied. Should have applied more pins over here and here. This was missing, so we need to non-union. We removed this and did applied Ilizarov and did accordion method. 3 cycles of accordion in here of 3 each, and you can see a very good union. So if you get a fixation has to be very good. Multiple pins has to be above and below. Rigid fixation, compression, and accordion gives a very good role in all these cases. So patient got married in this case with Ilizarov. So these are basic techniques. Suppose you are getting a very bad fracture with a stiff knee, a little late presentation. This is a case of knee flexion with exposed bone. We are doing a bone transport as well as contracture correction with the hinges. These are very important what to do simultaneously. we have corrected the joint, and you can see there's a long bone gap, 2 rings above, 2 rings below. We should also apply a foot frame also to avoid equinus. These are important tips for the youngsters. Again, a failed infected tibia nail. We removed the nail and did bone transport. These are very indications of the Ilizarov fractures. Again, a very bad cross injury of the ankle. It was very crucial whether we could salvage or not. We just consult the patient. We may also do an amputation. So we wait around 3 weeks to see the wound held away. The foot was warm, and then we applied Ilizarov, removed the dead fragment, and we did bone transport. So judicious part, this is a primary fixation. No H-fix was applied. It was just a slab. Waited for around 2 weeks, then we did the Ilizarov. These are the tips for the youngsters. You can apply Ilizarov. Foot frame is very important. You can always fix the fibula with a Ilizarov wire to hold the pillar, to hold the length of the leg. And we just have to ask the patient to walk next day, no bed rest. You can see the transport has been done in this case. Another case of long bone transport. I'll be teaching some tips for this. So delayed clinical decision for Ilizarov, patient came from Rajasthan, saved from amputation, joint was stiff, and there was equinus, there was long, but it is around 6 months, dribbling bus. So my message is, you apply a fix, don't wait 6 months. Do an Ilizarov in 2 weeks only. So the long fragment can be removed. It's a 19 centimeter gap. Foot frame is important, spanning is important, femoring is important. Temporarily, I removed the ring later because there was a very small segment over here. It's a very small trifocal transport, 2 above, 2 below rings. So a few points are very important. We have to wait for the soft tissue healing. Then another point is very important, that soft tissue impingement in long bone transport at docking. When there is come near to the this part, we have to do an excision of the soft tissue here. It's very important, it's very important, and acute docking is very important. So debridement and acute docking is very important when you have a soft tissue impingement. So these cases, you can see a translation was there, long bone transports were done. There's a mild alignment translation and long bone to see how to check the mild alignment. You can do minor procedures in between so that this alignment is good. The fragment is very, very small. So you have to use drop wires also in these cases. And so mobilization is very important in all these cases. Patient has to be promoted in all the fresh fractures, all the Ilizarov cases. Patient has to be promoted for activities of daily life, like grooming his house, raising the child, walking on the road, climbing the stairs, walking on the street. So these are very, very important parts from start to end, so that patient gets a very good result. So after doing all this, you can just have a very good result in all the cases. Patient can be saved, limb can be saved, so you can be running on milk stop. So the basic tips in long bone transport in fresh fractures is that we have to do long bone transport. Just remember a few things. We have to calculate the bone gap. This is the bone gap, the soft tissue condition, debridement and dressing, the ring placement, corticotomy. The mode has to be bifocal or trifocal. This is a trifocal bone transport. So the gap is more. Then transport is docking, regenerate, consolidation, maintenance, dynamization. These are very, very important points. Very chapter. Ring removal, brace slab. You can apply a slab or a brace. We have to check up for the risk also. If there is a risk of refracture, you can apply a brace in all the cases for another 6 months. Bracing is very, very important in all the cases. And there is infection, you can just do a debridement. You can apply a nail also post-op if it is needed. So suppose this case is taking around 2 years. Can we do something more for this? In cases when the skin condition is good, you can also use hybrid fixation like transport of a nail. I've been doing in a few cases, not all. But with an expert, we can do, but when it is indicated only, the skin good is connected. So this is very riskful, but this you have to have calculated your risk also. This is a compound fracture. You have used drop wires, and I've done transport over tense nail. You can see the tense is exposed, but you have to do, if you do a very good lavage dressing all the times, I've done multiple, more than 20 cases like this. I have a series. The wound stays very well. You can do transport over nail. Ring time goes less than half. You have to, there's no angulation, no displacement. It's a stable, you get a stable consolidate. There's no soft tissue invagination, stability, no risk of refracture. These are points you can use in different tips. Like long bone transport, you can 2 years versus transport over tens in these cases. So we can also do bone transport over tens, like hybrid transport. These are the cases of transport over tens. And the case of failed tens, you can see soft tissue loss was there. This fragment was removed and transport was then our case. And the result is very good in all the cases. Skipping all this, These are several cases in progress. We can also, in some cases, if everything is good, the skin is good, we can do fix with a nail also. It's a very bad compound trauma, fresh trauma. We do the Ilizarov, put an TENS, and we do transport our TENS. And after some times, when the transport was done, when the docking was good, we just found the skin condition was very good. And some consolidate was there. We wait for another 1 month and applied a nail in this case. So just in a few cases, very calculated, out of this, you can apply a nail to save time. This was removed in around 3 to 4 months only. Otherwise, you have to give 2 years. So you can see the skin condition was good. So just remove the, after this docking was done, we just removed the ring, applied expert nail in this cases. It was removed in 9 months only. So 2 years versus 9 months, you can see the, this is a expert nail. There is a special screw, pre-made screw. The calculator was there when the transport fragment will go. We just had a custom screw to hold the transport fragment, to hold it well, and lateral results were very good. So just in 9 months, it was removed. There's no reason fracture skin was very good. This is the radiographic outcome of the same case for this transport, our nail, and the clinical example. So these are only few cases, not in all. You have to be a little expert for this. This case now is added in my center. This is another case of fresh Ilizarov fresh fracture. Left was ankle only, right was there is a bone, dead bone was there. We just started, we put Ilizarov as a primary fixation. We put Ilizarov as a primary fixation and we started bone transport after maybe 20 days when the wound was good. So these things can be done. Transport is almost being done. Now the wound is around very small. So these are very tips. You can do transport over expert nail also. This is another chapter. Soft tissue, regarding soft tissue coverage. You can do flap over Ilizarov. Suppose there is a fracture, bone is exposed, but the skin, the bone is not dead. You don't need to remove the bone. You can try saving the bone, apply Ilizarov, see the condition of the skin after some time, maybe after 2 to 3 weeks. You can apply a flap, remove the wires, remove the wires for the flap, and then again apply the wire. These are important tips. So you need to do bone transplant. All the cases, the bone is viable. You can do flap over Ilizarov in these cases and save life, save the time for the patient. Similarly, we can do skin graft as shown earlier also. The case of skin graft over Ilizarov, we can remove the wire, put the skin graft, and put the wires again when the graft has healed. In a few cases, when there is no major need of transport, it was a proximal tibia fracture of a constable. We just had a little bone. We just did multiple drills and applied wax. Very difficult applying wax over, but in a few cases, we can see a very good results. So wax over Ilizarov is also a possibility in a few cases. Post-op care again is very, very important. We can just have a amputation ready patient to a patient running his own shop only when the post-op care is very important. We have to do precise case, care, patient education, monitoring, rehab till the goal is achieved. You have to be very meticulous, very training is very important. So distraction techniques, as Sarah has already told, we have to start distraction post-cortomy 7 days. Wait for the cortomy. If the fracture is compound, we have to wait till there is no infection. We can do cortomy later after one month or 1.5 months when there is no fracture. Don't hurry. After cortomy, you can do distraction like the regular formula, 1 millimeter per day. Mark the rugs. Rugs follow-up is important. Exercise is very important. Range of motion is very important. There is pain. There is stitching. There is a joint motion reduce. Hold the landing, regain the lost range of motion. Then start it again. Change the pins. Again, the limb positioning posture is very, very important. Proper posture is very important to minimize joint contracture. You have to ask the patient to lie prone and this hip extension stretch. These are very important exercises. Don't put the pillow like this, put the pillow like this so that patient doesn't end up in flexed knee. These are very, very important tips for Ilizarov and fresh fracture or knee fracture is very important part. So these are, we should just keep this in mind. Ankle pumps, prone lying, spine ankle, foot strap, prone lying, extended knee. These are very important tips. So hip abduction, hip extension, hip raise, these are very important. Range of motion is very important in all the cases. You have applied 5x rings, so the range of motion very important whenever needed. Pin side care is another important point. You have to do pin side care. Wash with saline, Ceflox drops. You can use betadine, spirit. If it is close fracture, patient can allow patient to bath or swim also. Otherwise, you'll end up in a very bad infection. You'll end up in trouble. Stability frame, as Berasal is already 10 grade, is very, very important. If it is loosened, you have to tighten the pins. Don't hesitate in changing the pins. You should change the pin if it is loose, if it is infected. But because if the patient stops walking, there's a vicious cycle of osteoporosis, loss of fixation, pins and sepsis, further decrease in walking. Ambulation again is very important. Weight bearing scale, earliest tolerated. Next post-op walk is very important, and heal first. You can use heal. Physiotherapy again has very important part. You have to train the patient for exercise, mobilization, ambulation 2 hours per day at least. So these are the different exercises like tibia bone, like prone lying, straight SLR, SLR prone, SLR raise, heel slides, knee extension, short quads, heel quad stretch, heel raise, quads in sets, long guard quads, crutches and walkers. These are different sets of exercises for the hips and thighs, abduction, lateral raise. These are long list. Not going into detail. These are very important exercises. These are the sets of videos for the tibia. All the trauma, all the Ilizarov patient must always do. These are the set of exercises for the femur. This is very important exercises for all the cases. Range of motion is again very important. Weight bearing is very important in all the cases. Activities of daily life has to be promoted in all the cases. You can see patient is driving a bike with the trauma and ring on this. So the patient, the ring is stable. You can allow all the activities of daily life. The recent case, patient doing transport is driving a scooty. And the process, so it has to be always promoted. Before you remove the frame, check for animation, check for the stress, X-rays, check for the stress test. Weight bearing, you can apply a brace, you can apply nail if needed, if you have risk of fracture. Follow-up is again very important. Rehab, brace and X-rays. These are the few results post-op in the upper limb. Few results on the lower limb. Patient is doing gym. These are very important. Patient should be promoted to do everything. Patient can swim, patient can go gym after removal to gain a complete normal life. So always keep the Ilizarov armamentarium in your OT. Be a good trained Ilizarov surgeon so it can save your lives. The take-home message here after such a long talk, like Ilizarov and compound trauma for limb salvage and reconstruction is an excellent device. If proper application is done, it's a wonderful primary fixation device. Good knowledge, experience, and training fellowships. Very important. It's a modular implant, can be adjusted post-op also. Soft tissue is not a problem. Joint weaknesses is not a problem. Intra-articular is not a problem. Activities of daily life can be allowed early. So the hashtag goes like Ilizarov saving lives and hope is life. So my QR code you can just save. Thank you. Thanks a lot.
Mesmerizing presentation. I hope all sorts of cases you have done, the most difficult one, with the conventional surgeons cannot do or think of. And that's the strength of Ilizarov surgeons. Now, any question? Yes? Anyone? Thank you, Dr. Hoda.
Thank you,
Your
sir.
excellent presentation.
Thank you, sir.
Thank you, Dr. Hoda, for this nice presentation. I just want to add 2 points.
Right,
One
sir.
is that it has been told that for gastrulation 1, 2, and 3A, we can do internal fixation. But there is 2 points. The patient should be attended within golden hour. Within 6 hours, if it is intervened, then only we can do internal fixation. Otherwise, Ilizarov is the choice of treatment. Next point is we have to see the patient where there is any comorbidities like diabetes or steroid dependence or immunocompromised patient. Even for these patients, even the patient in Gastrilo 1, 2, or 3A, we should go for external fixation or Ilizarov fixator. So we should also look after these points when the patient comes with the compound fracture or emergency. Thank you.
Thank you, sir, for the golden tips and very important points.
One point, Dr. Hoda, you have done excellent presentations. We should make a paper that type 3B, where Ganga scoring with above 14 amputation is suggested, that we Ilizarov surgeons has saved so many things, so many cases with 3B, 3C, but no paper is there. So we should focus on it, we should highlight it, That will be a great reference point also. Okay.
Thank you, sir. I agree, sir. Thanks a lot, sir.
Okay, sir, so should I proceed with my presentation?
Please, please.
Yes.
Okay, am I audible,
Yes,
sir?
sir. Thank you, Dr. Hoda. Okay.
Thank you,
Thank you,
sir.
sir.